I am Judith Matloff. I teach conflict and crisis matters here at Columbia, and that will suffice as introduction of myself. I want to start out by talking about 20 years ago. I used to be based in Africa as a correspondent. I actually knew John then, and there was what seemed to us a very scary outbreak of Ebola in what was then called Zaire, Democratic Republic of Congo today. There were 4 people that had Ebola. And I remember thinking, this is a disease that sounds like something that would be in a B movie, like the Attack of the Killer Tomatoes. I mean, it just seemed like the most, like you couldn't really make this up. A disease where you could catch it just by touching somebody's hand, if they had infected fluids on their hand, a disease that at that point there was no cure, and a disease that made people drown and die in their own infected fluids, defecating and vomiting and blood and hemorrhaging. It just sounded too horrible. And I was very, very relieved when my editors said, you don't have to go cover it. I worked for the Christian Science Monitor at the time, and for those of you that may or may not know the Christian Scientists, they don't believe in medicine for disease, and it gets complicated if a correspondent then goes out and gets sick. So they said, you don't have to cover it, and it's fine. And I actually remember thinking I was quite relieved at the time because we didn't know how to cover something like Ebola. What were the protocols? And I began to think about this several months ago because the same thing was happening, but on a much more horrific scale. Journalists were going out to cover an Ebola epidemic, and this one was much, much bigger, and we had no protocols. We didn't know how to do it properly. And it raised so many other issues, as well as just how do you cover the safety. Safely, we haven't had a gigantic epidemic on this scale to cover, really, in most of our professional histories. I mean, this is one of the biggest international health emergencies we've had to encounter. And how do you cover something of that epic horror? Aside from the safety conditions. And there were also the ethical considerations of a disease like this where people are dying in a very undignified way. How do you lend them respect and dignity as you're chronicling what they're going through? And then the whole question, which we became quite aware of in Dallas and even a little bit here in New York, of how do you report responsibly on a disease and inform the public without making them hysterical? So these are all issues that have come up over the last few months, and they're bound to continue. I think at last count, the World Health Organization put out data yesterday showing that more than 17,000 people are infected, of which more than 6,000 have died. So we're going to be dealing with this crisis and this emergency for months to come. So I'm absolutely thrilled that we have an exceptional bunch of people here to tell us what to do and to contemplate some of these issues. And I'll start by introducing them. On the far left is John Moore, who has been to every conflict zone in every crisis area in the world. I'm not even going to read to you the list because it would take us all evening. And he works for Getty Images. He's a senior staff photographer with them. And again, he's won pretty much every major photography award that one can win. So again, this would take me all evening to go through that. And John has made 2 trips to West Africa to cover the Ebola crisis, and he was one of the first one of the pioneers in terms of trying to figure out protocols. On my very direct left is Christopher Tedeschi, who is an assistant professor of medicine at Columbia University. He's both a practicing physician as well as a teaching one, and his specialty is global health emergencies. So we're very, very lucky to have him here because we can get the perspective of medical practitioner, which we journalists are not. To my right is Michael Goldfarb, who, the other thing about Chris, which I've got to mention, is he had worked as a documentarian before this. So he also comes at this discussion from the point of view of somebody who's worked on videos as well as a trained physician who's a specialist in these type of things. Michael Goldfarb is on my right, and he runs crisis communications and communications generally in MSF, Doctors Without Borders. And they have been at the front line of this crisis more than any other organization. And so we're very lucky to have his expertise. He also used to work as a journalist at Time Inc. So he knows what it's like being out in the field. And on the very, very far right is Todd Frankel, who was he was the first reporter for the Washington Post into West Africa in August. And that was sort of his baptism of fire. right, in terms of medical emergencies. And I have to read to you one of the titles of one of his articles, which was Love in the Time of Ebola, which I just thought was brilliant. And before joining the Washington Post, he was a staff writer for 11 years at the St. Louis Post-Dispatch. And he's been recognized with a long, long list and litany of awards as well, including on a team that won the 2009 Pulitzer Prize. And he's been in several anthologies, too, of the best American journalism. So we're very, very lucky to have these folks on the panel. And I'd like to start out with Todd. If you can tell us, when you went out in August, is this like distracting, or can you hear me okay through this, or should I just not use it? It's fine, okay. Can you, like that? Okay, is that fine? Okay. Todd, if you can tell us, what was it like to go in August? There were no protocols. You had never covered this type of thing before. How did you decide how you were going to do this safely? What was going to be your MO? If you can talk us through that a bit. And what was it like when you got there, and what did you expect, and who did you talk to get some advice on how to cover this story?
Hi. Yeah, so we've thought about this a lot, this issue of how to cover Ebola, because we know how to cover wars, and like if I wanted to find out, what to do in a war zone, I had people I could talk to. I could look up advice, but there's no one to ask about how to cover an Ebola epidemic, especially of this size, right? We'd never seen one before. And so we found ourselves in this weird position of making it up on the fly. And it was a little unnerving doing that. And what we relied on a lot was actually the CDC was actually quite helpful in not giving us advice as journalists, but as advice as what were their medical professionals doing to keep themselves safe. And MSF actually was quite helpful as well in explaining what they did as medical professionals. And so usually, you don't cast yourselves in their roles, but I sort of approached it as if I were going to be, I did not go into a treatment center. Actually, MSF told me that they would allow me into the treatment center, but I'd have to stay for 21 days. So I was not going to go into a treatment center. But it was a really technical experience to talk with the CDC and talk with MSF about all these different precautions. And it really boiled down to don't touch anything, which is actually really difficult to do, and bleach. It's actually also amazing what you can buy on Amazon. I was able to buy, and I didn't use any of this stuff, but it gives you a sense of the mindset of trying to cover it. I got one of those full PPE bodysuits. I had the gloves, I had the mask. I bought big rubber boots. I bought splash glasses as if I were going to go into a treatment center and be treating someone. But I just got that actually for peace of mind. And actually the other reporters who have gone before me and after, a lot of them have taken that as well, just for peace of mind. I actually never pulled it out of my backpack. I carried it with me the entire time. I pretty much relied on bleach. So I made up this little homemade solution of bleach solution. And I think it was MSF or WHO's guidelines of like the concentrations to use. And it was like the 0.5% for your boots bleach solution, and then 0.05%, and I made it a little bit stronger than that for your hands. And so, most of my clothes were destroyed by different bleach stains. But it was a psychological thing. And quickly, originally we actually wanted to go, they first approached me about going in July, and we really had no idea, like, do you just drop into, I ended up going to Sierra Leone, and you just drop into West Africa, and where do you do from there? And so what we thought is we'd approach it like a war, and when we generally go to war, you embed with somebody. And so we thought, all right, great, we'll embed with somebody. And so it turned to the CDC, and we had lots of negotiations back and forth about me embedding with them. And it ended up falling apart, and I ended up going anyhow. It was a harrowing, psychologically, it was a harrowing experience. Actually, the worst part was before you go. I think a lot of people, when they talk about, I've talked to since about covering Ebola, it's those days before you go that are the worst, when you're imagining how it all could go wrong. So there was a lot of that.
Did you get training to use the PPE, or did you just have it?
No. Actually, it's funny. Now they send reporters who are going to like some sort of like 3-day like survivalist school. When I went, they had nothing. I guess, just wasn't a thought. So I wasn't really sure what to do. And as we've learned since, right, the biggest problem with the PPE is taking it on and taking it off.
Taking
And
it off.
so I'm really glad I didn't have to do that. Yeah, I was just going to throw it on and hope it worked, and better than nothing, I guess, right?
Do you want to talk about it from the medical perspective?
Sure, I
Is
mean,
this
we
making
could
the
certainly
skin
get to
crawl?
it, but, in some ways, it was terrifying to you then because we really don't have too many established protocols for people that are not healthcare providers, and in a sense, we still don't.
Right.
The CDC has done a great job at kind of refining their protocols for healthcare providers, but there's not much guidance out there for people that are working otherwise in the area. And the PPE, in some ways, is a great psychological crutch, but I also would worry that sometimes the PPE is a little bit of a false sense of security.
Sure.
Because I mean, I have people in my department, the Department of Medicine here at Columbia, that are ordering Tyvek suits on Amazon. And if you feel that you can put on that equipment, use it properly, and take it off properly by yourself, then that's actually a little bit terrifying.
Yeah.
So the real question is, how do you mitigate the risk? How else can you mitigate the risk?
Can you talk through, it's not like a 20-stage procedure to take it off and you have to have somebody watching you. Can you talk
So-
us through that a bit?
Certainly, the protocols that folks like MSF are using in Africa are a little bit different than the protocols that we're using here. Columbia, as a matter of fact, this week opened our biocontainment intensive care unit. So I've spent the last 3 days getting into and out of PPE. And it's a 3-person, 20 to 25-minute intense process to remove that equipment. And it can be kind of scary when you think that, if one step is skipped, there's a problem or a potential problem, and it involves, bleach is the answer. Clorox bleach wipes. If you want to buy stock, Clorox and DuPont, whoever makes Clorox and DuPont are the places to do it. Clorox bleach wipes are, I think in our protocol, we sanitize our hands 9 or 10 times while we're taking the PPE off. And that's obviously when we've got all the Clorox bleach wipes in the world available to us. But it's a big deal, and I would be afraid for someone that had that false sense of security, rather than being very careful with the question of, how can I mitigate this risk? Is it not touching things? Is it choosing where and where I don't go? Is it learning about hand hygiene and some of these other things that are probably, and even travel safety for that matter, are probably almost more important.
No, yeah, oh, yeah.
Well, I was just going to add that it's precisely that potential for the false sense of security that PPE can provide, which is why we don't permit media, amongst other non-essential personnel, into the high-risk areas of our treatment facilities. So essentially the treatment wards, where the medical staff are doing the work, are in direct contact with the patients. Naturally, media want to access that. That's where the story is, after all. That's where the patients are. But it's precisely because even if you have the equipment, you have the PPE, even if you have some semblance of training, you may not have the type of training that MSF provides. And we do, before even our very seasoned medical staff, many of whom have prior experience working in hemorrhagic fever settings, they still have to go through a mandatory 2-day training in Brussels at our operational center there. And much of that is focused on what we call the donning and the doffing of the PPE. And it can differ from probably the training that, Chris, that you're receiving, and that's due in large part to the really very different medical settings that we're talking about. You use the hand wipes. Our folks are sprayed down, head to toe, after removing each article of the PPE. So it's from the first cases and from the first instance that we set up our treatment facilities back in March in Guinea, we were inundated with media requests and for embeds. And to get into the treatment units, and we just imposed a blanket policy of no non-essential personnel, and that would include people like me. If I were to be in the field, even though I'm MSF staff, I wouldn't be granted access. And it's also just to prevent any accidents, to make it as easy as possible on the medical staff. And we realize that imposes some challenges for the media.
Sure.
By not allowing that access. We get that, which is in part why we had provided video footage, B-roll, to outlets from the insides of these facilities to try to meet some of that demand.
Yeah,
There's kind of a tough parallel there between, the analogy that you use, which is the most familiar one, which is covering a war. And I think a lot of people, maybe more so freelancers or people that are used to sort of traveling around on their own, you can embed with a unit, you can enter a war zone, you can enter a conflict zone, and with a little bit of, this is not something I do, so maybe, stop me, but with some common sense and some luck and a little bravado, you can oftentimes get in and out of that situation. And then once you're out of it, it's done. You've made it out.
Yeah.
And this is very different and needs to be approached a little bit differently, I think.
Yeah.
Yeah.
John, can we get your input here? I mean, you were one of the first journalists that did wear a lot of protective gear. Can you talk us through the decision that you went through, the training, how your second trip was?
Compared
And
to
also
the
the
first.
whole question of, since you have done so many conflicts.
Well, certainly, when you go into hazardous situations, you have to take the appropriate gear. In this case, as Todd mentioned, there were no instructions that you could open up and read before covering the Ebola epidemic. I went online. I spoke to journalists who had been covering this already in Sierra Leone before I went to Liberia. Really, what got my attention, and the reason I went in the first place, is when I read a New York Times story that quoted the MSF chief in Liberia as saying that the situation in Monrovia was potentially catastrophic, and that would have been the first major urban area to be hit by this epidemic, by this virus ever, of that size. And so I started talking to journalists who'd been there, and there weren't that many. And I went online. I bought my Tyvek suits, and not just one or two. I got 24, and that's of everything. And I meant to buy 60 pair of gloves, and because I didn't really understand the particular website, I bought 600 instead, and so I was well equipped. The goggles. Let me go to the computer here because I'll show a couple of pictures while I talk. It'll be more interesting that way.
Do you have a
This-
choice of color?
It was white or white. Only MSF gets the yellow ones. When I first ordered my protective clothing, they call it PPE, personal protective equipment. I got the wrong goggles. They came in the box, and I put them on. I decided it was worth trying all this stuff on before I went to Liberia with it. And I started breathing through the surgical mask, and the open plastic glasses that I had on immediately fogged over. I couldn't see anything. And so I went to a sporting goods shop, a scuba shop, in fact, in Midtown, and went and bought dive glasses and swimming goggles, which closed, and also some of the type of liquid you can buy to keep from fogging up. And so I learned how to use all this stuff before I went, and to a certain extent, as Todd mentioned, you didn't have the training back in August. And so this is what it looks like when it's all on. I have, as you can see on the cameras, there's a rain protective plastic covering, which is used by many sports photographers when they stand out in the rain for all those hours covering games, shooting with long lenses. That covered everything except for the front of the lens, which had a lens filter on it, which could be sprayed and wiped off, and the camera straps. And by the end of my assignment, all my camera straps were bleached out, and they did not make the return trip with me to the United States.
What did your subjects think when you're like coming at them like that? I mean, it's always hard to have a camera anyway between you and a subject. What is it like to have a man wrapped in plastic with a lens?
The spacesuit.
Yeah.
Really, I did not walk around like this on the streets. Number one, that would have been, people are terrified anyway, and to see this guy here walking down through villages and city streets would have been much more so for them. And so I only wore this equipment when I was in very specific areas. as Michael has mentioned, they did not allow media, and they still do not, into high-risk zones of the Ebola treatment centers for very good reason. But I was able to go into some of the Ministry of Health centers, the isolation centers, and I'll show you a couple photographs of what that looked like. This was my first day there. When I arrived to Liberia, I met with a couple journalists for dinner and talked, and my fixer, who was also my driver, and also a translator. Although people, the English is the language of the country, there's dialects and there's accents that can be difficult. And so he worked in all those capacities for me. And so I went out with him and a few other journalists. We talked about where to go the next day, as we do when we're covering any story. And I went to a school which was had been a U.S. aid-funded school. It had been closed, like all schools had, because of the epidemic. And just as I arrived, they were bringing people in ambulances, and you know, very difficult situation. These people are very sick. I put on my protective gear, and the way really I learned how to do it was with the Ministry of Health and the Red Cross health workers, because they do this every single day, especially the burial teams, and I think you'll see a picture of that coming up. They put them on everything on in a very specific order, as we've talked about, and what's more important, take it off in a very specific order. And it's not just one pair of latex gloves. You're wearing several pair, because that first pair comes off, and that's a dangerous pair of gloves. And then you get sprayed down with chlorine and bleach spray. But really, in my case, because I was not physically handling sick people, I wasn't aiding them physically, I wasn't touching anything except for one part of my body, because we don't levitate. The bottom of your feet is what touches the most infective areas.
Were you using a telephoto lens in order to maintain, what is it, 6 feet or 9 feet distance? What's the?
Well, 3 feet is the
Oh, 3
is the minimum.
I was not getting closer than
distance,
3
yeah.
feet. But
6
no,
feet's
I mean, most
better.
of the time,
feet's
when I was, especially inside, I was using a wide lens. I was fairly close. In fact, my driver, especially on my second trip, I had a different translator driver. On certain situations outside, he'd be parked behind me in the vehicle watching what I was doing, and on a couple occasions, I'd hear him beep the horn. I looked around, I'd walk back to the car, and I said, "Frank, what's up?" And he'd say, "Mr. John, you're too close to that person on the ground. Take a few steps away." And so I literally had someone watching my back, and I was very grateful for that. And you'll see in these pictures here. I'll run through a couple frames so you get a sense of what it looked like. There was a very real problem in that, especially early on in the epidemic, there was a significant percentage of the population who did not believe that Ebola actually existed. And in fact, the UNICEF and the government's campaign to educate, to bring awareness, was called "Ebola is Real." It was as simple as that. A lot of people thought it was a hoax, and designed to bring in international funds, and that people were dying for other reasons. And behavioral change is very, very difficult. And before behavioral change happens, people have to actually understand that there's a problem. And that's what this woman is trying to explain to people here. This photo here, there was this isolation center you saw from the blue room. This mob, this crowd, to be more generous, was very upset that they'd opened up an Ebola isolation center in their neighborhood. This is the West Point Township. They marched on the center, broke through the gates, and pulled out the patients, telling them that they were now free. And proceeded to, after I left, after these pictures were taken, I decided it was time to go. And you get a vibe, especially in a crowd or a mob situation, and you follow your instincts. And my driver took me away, and afterwards they looted the Ebola isolation center of all of its mattresses and medical equipment, which I think probably caused some additional problems in the neighborhood. This boy had been rescued by the crowd from the center. Of course, once he was out in the neighborhood, no one wanted to care for him or touch him. His name was Exco. He was 10 years old, and He was on the streets a couple days when I located him, and this crowd, they didn't know what to do with him. Some wanted to help. They didn't know what to do. Eventually, he was given some medication that night, taken to a Ebola treatment center, and died the next day. Once you reach such a state of dehydration, people go into shock, and they're in such a state.
Can I just interject?
Yes.
Because I'm an interjector. If we can go back to that, he's naked and he's a minor. What sort of ethical issues come up about
Well,
something like that? Because obviously, I mean, this picture is so powerful. It shows the alienation of this kid. He's in an absolute abject state. But did you weigh these kind of questions when you're taking pictures? You know, I can't take that one, even though it really depicts the scene. How do you decide how far you can go with depicting the gruesome?
generally speaking, I try not to show genitals when I'm photographing people in states of undress. That's kind of where the line comes in. Of course, in the U.S., we have very strict rules on photographing children in any private place. We don't get Getty Images. We don't go into schools unless all the students have photo releases signed, and often they do that at the beginning of the year at the schools. In Liberia, that's not it's not really the case. There were no legal issues to deal with. There were more ethical issues, and I tried to photograph people so that I didn't abuse my access, and I did the best I could.
Yeah.
This picture here, I'm sorry, Judith.
Oh, yeah. I just want to know, Michael, at MSF, because you had a team documenting the crisis, did this issue come up at all? How far do we go to show just how miserable the situation is?
Yeah, I mean, it comes up probably on a daily basis at any of our project sites. I mean, not just in the Ebola-affected countries, but we produce a steady stream of communications materials. When I'm in the field, I'm shooting or doing video or written narrative. John brings up a good point about releases. I mean, we always try to get informed consent, but what does that mean in a medical facility with people who have never seen a magazine, let alone been online? So do they really understand when you explain to them? I'm here to tell your story. So it's always a bit of a not just a challenge, but a bit of a blurred area. When our rule of thumb, or at least mine, when I'm in the field in a production capacity, is when I'm witnessing someone in distress or in extremis, I'll ask myself, if that was me, would I want to be depicted in that state? And if the answer is no, then then you try to find some ways around depicting them in what you would presume to be a more respectful manner. But the flip side of that is that we tend to make assumptions about what people's preferences are, and that are often based on our own cultural and our own values. And very often, people will want to be photographed. That's at least been in my experience. That despite their extremists, it almost because of it, they want to be photographed. They want to be able to communicate their and their community's plight, and they will ask even to be photographed, or at least not refuse. So it's we also have to be, me and my colleagues, we do try to be mindful of that as well, of what maybe their preferences are, and try not to make assumptions or decisions for them. But certainly, I mean, we try to avoid photographing, certainly genitals. If someone is in obvious, medical distress, I wouldn't want to be, if I was in suffering from Ebola, I certainly wouldn't want to be photographed, vomiting and being, suffering in my own bodily fluids. So, I mean, in some cases, it's a no-brainer.
Yeah.
Yeah.
Right.
But it's certainly, the ethical issue is certainly one that we confront daily.
Was this something that came up in the Washington Post before you and the photographers went out? I mean, did you have a discussion with the editors before you left, or was it something you kind of dealt with, as one does, improvised day by day?
I think it was something that we just sort of followed the protocols we would have had, like, again, the general decency sort of protocols. We never specifically decided we're going to treat Ebola differently. But yeah, just that feeling that, try and be respectful, especially like then this is a culture that that is very poor, and West Africa had a lot of issues and a lot of problems well before Ebola. And so, try not to, you don't want to be vulture-like in your coverage.
I skipped ahead to a picture here that addresses this particular issue specifically. This Red Cross team had arrived to collect the body of a woman who died that morning, and there was a good 20 minutes while they put on their protective clothing, and I was able to talk to family members, and really. The way my introduction goes is fairly consistent in all the times I've photographed family members there in Liberia. I'll say I'm John Moore. I work for an American photo agency called Getty Images, and I'm so sorry to be here. With your permission, I'd like to stay and photograph. And some people would say no, I wouldn't like that. And certainly in the case of this picture, there was one elderly woman who didn't want her picture taken, and the last thing I want to do is make their life worse in one of the most vulnerable moments of their family's existence. And this particular woman here was the sister of the deceased. And she didn't have any problem with photographs being taken. Now, did I ask her? I said, well, if you start crawling on the ground and you look really distressed, is it okay if I take pictures? Then no, I wouldn't. But you have some sort of consent, and oftentimes when you're wearing PPE, you can barely speak to anyone. You have a surgical mask on. And oftentimes you don't actually get complete verbal consent. Is it okay if I take pictures? Sometimes things are happening, and it's more of a consent that you get by looking at someone, and they look back at you, and if they want you to go away. You have your camera. There is some sort of consent, and sometimes it's very subtle. But if you had to get written consent or complete verbal consent for every photograph you take, we actually wouldn't get any work done at all. We wouldn't show what's happening. So it's very delicate. It requires us to have a lot of sensitivity and be willing to put your camera down and not take pictures at certain points.
What temperature? I mean, it was hot and humid, and you're wrapped in all this stuff. How long could you stand there with the PPE on you while you're shooting?
Well, I think for MSF it's 1 hour that they work inside.
Well, that's inside the treatment ward. Yeah,
that's right.
Yeah, which are not air conditioned, and they're enclosed environments. So yeah, the medical staff, I think it's max 90 minutes that they're inside. So they'll go in, they'll do a shift, and then they have to rotate out because of the risk of somebody becomes dehydrated, somebody faints. Right. You can imagine what can happen in a setting like that. You knock into somebody, you get a needle stick, whatever. You mentioned, you benefited from a sort of buddy system with your fixer, and and our protocols are such that no one goes into the facility alone. You're always buddied. It's a consistent buddy system, so that they're always watching out for each other.
That's right. And in the case of these Red Cross teams, I was going into. I'll skip back to another photograph so you get a better idea of what it looks like. Most people live in one-room houses in Liberia. Some families have bigger dwellings. This one actually had a corridor. I was able to walk in with the team and stand in the door and photograph into the bedroom as they were spraying down this body before they took her away. And whenever I got dressed, I would get dressed with them, and when I was done, most importantly, you take the clothing off with the health team, and they may have 8 pickups a day, and it takes a huge amount of time. It's very tedious for them, but you go through this process, and you go through every single step, and you take that stuff off very carefully, one piece at a time, and you get sprayed the whole way through.
benefits of wearing this stuff in New York? Where
In terms of-
it's a more controlled environment and whatnot?
In terms of comfort and
Yeah.
safety,
Yeah.
our limit is 2 hours. And that includes most likely the 20 to 30 minutes it takes to remove it. We're lucky to work in obviously a more climate-controlled kind of setting, but at the same time, it's hot as hell in there. And that's in an air-conditioned room. The people that will end up wearing it for the longest, here are the nurses and caregivers, and for them, 2 hours is probably the very most. There's not much you can do wearing all that stuff in terms of medical procedures and putting in IV lines and putting in, doing respiratory procedures. You're super limited. You can't even, put a stethoscope in your ears, let alone do a lot of other kind of more complex things. So it's pretty limited.
I'm happy to put through these photographs, are somewhat rare images because the Ministry of Health did not want journalists photographing the cremations. The cremation is I think you could say it's taboo almost in Liberia. People bury their dead. There are rituals that go along with the burial of people's family members, and breaking with those rituals has been key to breaking the disease. And cremation is a very foreign concept there, and so they're very few photographers were able to get in and photograph some of this. I made it in one day and have a few frames, but I could never actually photograph the pyre being burnt. Really. In the evening, not really that well, and once again, I was never coming in physical contact with these remains, but I did put on the protective clothing just in case. On my first trip, I was very conscious about never touching my face. On my second trip, that was in August, my second trip in October, I was just very conscious about not touching anything. And so when one day I brushed my elbow against the frame of a door, I knew that elbow had touched something. And so when I came out, I had my elbow sprayed down. Of course, all the clothing underneath your PPE gets completely bleached out. So I did some clothes shopping when I came home.
Can you talk a little bit about, what it's like? I mean, you have to be alert when you're recording anyway, but suddenly you're vigilant to an elbow hitting something. What does it feel like at the end of the day? I mean,
It's exhausting. It's, John was talking about, touching your face. And people would talk about this little experiment, if you actually try to not touch your face. I think people touch their face like 6 times an hour, just subconsciously, or even more than that. So it's a real struggle. Like I said, I didn't put on the PPE or even take out my gloves or put on a mask, and that was because there were no protocols, and I was just following the lead of, there were lots of infectious disease docs who were just like flew over. They felt like the need to help, and so actually I latched on to a lot of them and went around with them, and I was following their lead. And no one put the stuff on, but again, no one touched anything. And it was actually interesting, I had a fixer as well, and a driver. For some reason, they had to be separated. But then after talking with an infectious disease doc, I felt very comfortable hanging out with my fixer and my driver. But then this question came up, what if your fixer or driver has Ebola, right? You're sitting in a car with this person. It's a person you probably feel closest to. I certainly did with my fixer on the ground. And so I learned from the infectious disease docs, the way they were handling that is every morning when they come out and meet their driver fixer, they would just sort of ask them hey, how are you doing, right? And it wasn't really a friendly thing. It was more it was supposed to be friendly, but it was really asking how are you feeling, right? Do you have a fever? Are you sweating? And so these little things where you just had to be suspect of everything. Eating. I brought a lot of food with me, tuna fish in the pouches and energy bars. But I also ate out a fair bit in the town, in Freetown, when I was in Freetown. Outside of there, I didn't eat the tuna fish. But you just freaked out about your server, right? I mean, just everybody, your cook. I mean, just every interaction you could possibly imagine. The beggars who would come up to you on the street, please stay 6 feet back. And when you're interviewing somebody, as a natural inclination, you want to get close to them, to hear them, if nothing else. And so there was this strange sort of dance that you would do, and they would get too close, just sort of put your hands up in the most polite way you possibly could to sort of communicate, hey, please stop there. And I remember I was talking to one guy, and, some people, close talkers, and like a little spittle comes out of his mouth, and, it freaked me out. I was like, did that hit me? And it really, Ebola is really a psychological fear factor, right, that no other disease seems to have. There are other hemorrhagic fevers that are just as dangerous, and other diseases perhaps in some ways, but this one just scares the heck out of you. And so it really was overcoming a lot of that fear and just day to day. And we were talking earlier about how when you come out of like a war zone or a conflict zone, or every story you ever covered before, when you got on that plane home, it was over, right? You sort of, slapped yourself on the back. Oh, great, I made it home, great. But this was different too, right? Because you came back and then you waited, 21 days. All right, did everything go okay? I didn't touch my face, I washed my hands, da-da-da. And again, the studies show that, the 10 to 12 day period is probably the most intense infection period. And so, when I came home, again, we didn't have this. Now, when you come back for the Washington Post, you don't come into the newsroom for 21 days. You stay at home. You don't have, not strict quarantine in your house, but don't come in the newsroom. They didn't know what to do with me. So I came back in the newsroom, ironically, at 12 days. I spent a week and a weekend at home, a little bit longer, and decided to come back in. But the entire time I was taking my temperature, and I think it's officially they take your temperature twice a day, which I thought was interesting, because I was taking my temperature like every 2 or 3 hours, just because if I have a fever, what am I going to do? And another issue too is malaria was actually another big concern I heard a lot from the CDC and MSF. And antimalarials and wearing long sleeves and making sure I was covered in DEET, because I didn't want any reason to spike a fever, because if you spike a fever, this is before we had these Ebola treatment game plan here in the US, and it was kind of interesting trying to figure out like what would I do if I did spike a fever, do I call my family doc, hey, so all those issues.
Would you have called CDC? I mean, what should a journalist coming back from an assignment do?
If you're within the 21-day period and you become febrile and you are legitimately at risk of exposure, I'd probably say call 911, because that is, you've now become a person under investigation, they say a PUI, unless you can sort of screen yourself out by way of your exposures. I don't know what you tell returning MSF staffers.
Well, we have-
are probably able to call MSF.
Yeah, I mean, we have pretty strict protocols for our returning field staff, and so certainly, the heart of it is a very rigorous self-monitoring, right? So, and I mean, and this played out. The protocols, were shown to be highly effective with the case of your good friend and our MSF colleague Craig Spencer. He was taking his temperature, the required amount of times each day. On that Thursday morning, he woke up, took his temperature, it was slightly elevated, he immediately called the office. And that set in motion a sort of
A predetermined plan.
absolutely. I mean, he followed the protocol to the letter. And so called the office, we immediately contacted the health department, and then EMS in PPE arrived, and then of course, once you have guys in spacesuits showing up in Harlem
You
or
attract
in any
some
neighborhood
attention.
in Manhattan, because I remember saying to our medical director in the office, I clarified with him, I said, will EMS be in PPE on arrival at the apartment building? He said, absolutely. I said, then we have to be prepared that this is going to be, this will be public within minutes. And in fact, it was. And all it takes is a neighbor to take a photo and tweet it, and then it's everywhere. And that's exactly how it played out. And I think the takeaway from that is that despite the fact that he followed the protocols, it was, once it became a story, and of course the story was Ebola is in New York City, all right? As if there was an outbreak,
Right.
as if there was a crisis, as if people
It's our
should-
worst fears, right?
Our
It's
worst-
the attack of the killer tomatoes.
Right.
In
Yeah.
reality.
Right, and that's where it became acutely challenging Certainly, for him and his family. And I think it's where, unlike the very thorough and, if not heroic, work that you, Todd, and John, and your colleagues were doing in the field, I think there was almost a disservice in the coverage here. And it had to take a couple of isolated cases in the U.S. and Dallas and here for Ebola to suddenly become, to finally get on the radar of major media. And the fear-mongering and the misreporting and the suggestion that people like Craig were acting irresponsibly and the vilification that resulted from that. And then, of course, once he was discharged, he was a hero. I mean, we were monitoring the media coverage quite closely, and upon his hospitalization, all of the speculation, that he, why was he out bowling the night before, and why was he, daring to move around the city, and this almost a refusal to explain how Ebola functions in terms of its as a contagious agent, and there really was, and that just whipped up the fear. People didn't understand that you can't get it from just talking to somebody who is not symptomatic.
I think for the reporters, suddenly and abruptly trying to cover that story, they ran into a combination of two tough spots. One being the absolute tabloid, horror movie, Contagion hits New York angle to the story, and the other, this very, very difficult space of needing to be able to explain risk.
Yeah.
And I think for people that are, medical and science reporters, this is probably one of their biggest challenge. It's really hard to explain the risk, when you even know the risk.
Yeah.
I explain to people all the time the risk of getting HIV from a needle stick. It's very well known, and that's really hard conversation to have with someone. When you are trying to explain the risk, what's the risk? Craig went bowling. What's the risk?
Yeah.
That's a very tough story to tell, and when you combine that with this guy went out and ate meatballs, and photographs and images and video to go along with it, it becomes a trap, I think, for someone trying to responsibly report that.
Who do you feel did the worst? Tabloids, TV. Who did it better? Who did it better? Who did it? Let's be positive. Who did it better?
I think it was more like varying degrees of irresponsibility. I mean, to be frank, and there was also some of that in the field at the beginning of the outbreak, especially back in March and April. Some of it, I think it got much better, but. In a heightened state, it is very difficult to explain that risk, but at the same time, it's also pretty straightforward, I think, when you explain to someone, yeah, he went bowling, and unless he had vomited on the bowling ball, and you had touched that bowling ball and then licked your hand, you were at absolutely no risk, even if he was symptomatic.
But the Times ran a piece the next day titled, "Can you get Ebola from a bowling ball?"
Well, but precisely from that perspective, that was Don McNeil's piece,
Right.
and precisely to challenge that fear mongering that was out there. Some of the most egregious examples were the completely unsourced reporting that he had lied to the health investigators, right? That were based on anonymous sources. I mean, it was in the New York Post, and of course, no other media picked that up. Because it was patently false, and as the mayor came out very strongly against it, and in fact the allegation was retracted. But these things take on a life of their own, and as soon as so on the one hand he's a villain, and then as soon as he's discharged, he's a hero.
Right.
And so, we were getting requests for as soon as he was discharged, he's this great American hero. We want to have him on the program. And it's the same media that were suggesting that he was a lying, reckless individual for daring to lead a normal life after working in Guinea.
And in some, again, I think it's a really big spectrum, but I think in some outlets the implication almost is, maybe the unspoken implication is almost is, well, what was he doing there in the first place?
Mm-hmm.
How can we put you put all of New York City at risk, you know? And that's a deeper issue, I think, to address, and it's very difficult to address in a very acute phase of a crisis like that.
And I think what was lost in this, I mean, ultimately, this was a discussion about public health,
Right.
right? And what was lost in that discussion was the infinitesimal risk that Ebola poses to public health in an advanced, you know, in a country with a highly advanced medical system, where you have mitigation measures, you know, A to Z. And lost in that was the fact that, you know, how many people does a flu virus kill every year?
Right.
Tens of thousands of people in this country.
Right.
Texas, you know, they're freaking out about a case in Dallas, while they have a measles epidemic
Right.
on their hands
We
because
had
people
one
aren't
on our
vaccinating
hands.
their children.
Right.
And no one's talking about
Right.
this. So including
Right.
the media, right?
Right.
So I think there was a collective failure, and I think this whole episode, especially when we had a couple of isolated cases here and the sky didn't fall, but I think it requires a soul searching and a reckoning about what kind of the disservice that the coverage, particularly in the U.S., because I think it set us back. It certainly took the focus off where it needed to be, which was at the source of the epidemic, the source of the outbreak in West Africa, where you have a true crisis. Where you don't have advanced medical systems, where you have people dying now you have the emergency within the emergency. You have people succumbing to malaria. You have
Right.
pregnant
Dying
women
in childbirth.
because they can't go to either the health workers have been decimated,
Right.
or people are afraid to go to clinics. So all of that was lost, right? So what our struggle, at least, during that period, was to try to shift the focus back to where it needed to be. And, you know, we were literally telling media, look, you want to stop it here, stop it over there. If you don't want Ebola here, stop it at its source. So pay attention to what's happening over there.
I mean, it's so hard to like say, okay, this is the solution, this is what we should be doing, but do you have thoughts of what can be done to wrangle the media better next time? And
I think-
when we say media,
yeah.
I know that it's such an amorphous term because it's Fox.
Well,
and
that's
NPR.
right, well, to Twitter, to Face,
Yeah.
to you know,
Right.
BuzzFeed. I think that there's a pretty stark difference between the issues that we're talking about domestically and the international coverage, I
Yes.
think. You know, the domestic coverage fell into the trap of tabloid coverage and very much sensationalism, and the same difficulty of being able to explain the science. You know, I think that there are of all the professional reporters working out there, a tiny subset of them make their career reporting science and medicine, and a tinier subset of them make their career reporting humanitarian crisis or
Yeah,
conflict.
certainly.
So most of the people, and that's okay, but the great majority of the people producing those stories are learning as they go along at best and falling into very predictable traps at worst.
In defense of media.
No,
Please.
And some people have done it in one, you know.
No, I was,
Right.
but I think it's interesting because you're entirely right about how do you explain the nuances of risk and stuff like that. But I remember what's that guy, Osterholm, the guy from
Yeah,
Minnesota,
Michael
Osterholm. So he wrote that op-ed in New York Times, like what the public health officials are afraid to tell you about Ebola.
Right,
It's
right.
airborne.
Right.
You know, and
Yeah.
so he introduced that, and he's gone on to say this in various different ways. And so if you want to freak people out, airborne Ebola is it, right? I mean, just
Right.
everyone's going to run for the hills. And so when we're trying to parse this and explain it to people and say, no, don't worry about it, it's not airborne, it's, you know, it's aerosol droplets, which is a very difficult concept. You know, the 3 feet and it falls out of the air versus the flu, which will go throughout the whole room. But then you have other people who have credentials, and he has a lot of credentials saying, oh no, airborne. So it makes our job even,
Right.
I think there's some public health or, you know, professional
Right.
problems as well, yeah.
There's sometimes it's hard to communicate that when it's a moving target. I mean, you know, the
Sure.
CDC changed their recommendations.
Yeah.
You know, full on, they came out halfway through this and said, you know, you can't have any exposed skin. And this PPE, you know, the CDC made a lot of changes, and they should, and they continue to. But when that story is interpreted as, well, you know, you can report that as, well, they don't know what they're talking about. They were wrong, and now
Right.
now they say they're right. Or you can try to convey that idea that as a clinical situation evolves, we learn, right? We learn, we've taken care of 4 Ebola patients in the U.S. It's going to change,
And we're going to have
the same
more.
side.
Yeah,
And there'll be more.
There'll be
right.
more, yeah.
Let's circle back to responsible reporting.
Well, I can, I'll, just on the topic of coming back in the midst of the hysteria, that's on my second trip in October, that's what I walked straight back into through JFK. In fact, the protocols that the U.S. government had put in place at certain airports only came into effect a couple days before I arrived. And in my case, I think, thankfully, things were handled quite professionally. I went to use my global entry card, which is a little identification that you have to whisk your way through immigration without actually having to talk to people. And I put it in the machine, and it said, "Please go talk to a person." And so I went over to the immigration official, and he said, "Where are you coming from?" And I said, "Casablanca, but Liberia earlier in the day." And he said, "Well, all right." He was very nice. "Come with me. I'll take you to this office." And I went over. There were some medical officials in surgical masks and gloves. They took my temperature, and they asked me a series of questions. I answered them all. My temperature was fine. They asked where I was going to be for the next 21 days. I told them. And it was in Connecticut, at a family home in Connecticut, not in the city. And gave them my phone number. And when I arrived to that home, the next day in the afternoon, I got a call from the local health department nurse, and she said, "My name is Rita. We'll be talking, for the next couple of weeks. Just I'll talk to you every morning, and in the evening we can text, and I'll ask you about your symptoms or lack thereof, hopefully." And we went through that, and at one point she said, "I'd like you to speak with the EMS director for the city of Brantford, where I was staying. And he doesn't know your name. You don't have to tell him your name. We want to keep everything private. We don't want TV crews on your doorstep." And I said, "That'll work." And I called him up, and he went through the protocol. He went through the exact protocols. If you spike a fever, call Rita. If you can't reach her, call me on my number. If you can't reach me, then call 911. And they have been instructed that to ask people who call if they've been to West Africa. And if the answer is yes, then they put out the call to the ambulance over a secure channel that does not involve the radio, and so it can't be checked by people who are scanning the frequencies. And so they were very, very concerned about privacy. And he told me exactly what would happen. They would arrive in the ambulance in PPE within an hour or an hour and a half after my call, and they would bring a suit for me. And I would put that on. They'd put me in the vehicle, and they'd take me to New Haven, Yale, where an isolation facility would be set up. And so, did I necessarily have to be in they called it voluntary quarantine. They had 9 other people in the state under what they called mandatory quarantine, which means there's a deputy or a trooper or a city cop in a squad car sitting out in the street. They didn't have to do that with me, and I did not go. I went out for walks. I went out for jogs. I did not go into businesses. I didn't mix with people. And was it necessary? Maybe not. However, I came back right in the middle of a national hysteria, and we saw what happened with NBC when their reporter went out and got takeout, and it was in Jersey. It was scandalous and very bad for NBC, bad for her, and made people very afraid. We didn't want to contribute to that, but we noticed how this the hysteria over this magically disappeared with the midterm elections.
Yeah.
And the lesson to
Yeah,
this
that's-
also is don't fly into Newark Airport.
That's right,
Fly to
JFK,
Jersey.
not Newark.
Yeah, that's an important. I think that's an important aspect of this. Is that had Craig and our other colleague, the nurse
Nurse
Casey
Hickox.
Hickox, if they had not come back Well, and that was within, I think, 2 days, right? Casey came back, and then Craig was admitted within, or
Within a few-
within,
four or
it was,
five
yeah, it was like the
But
same
it was after
48-hour
Texas.
period. It was, yeah.
Yeah.
And, that was, 10 days before the midterms. And I think if Casey had returned on November 4th, well, she probably wouldn't have been grabbed at the airport. And it was pretty clear this was it was a highly politicized time, and it was, two ambitious governors, trying to out White House the White House, right? I mean, there was trying to appear tougher on Ebola. So I think it would have been a completely different climate if it wasn't an election period, and I think that has to be kept in mind. Unfortunately, we were all caught up in that
Right.
in that drama, and it was very hard to kind of penetrate it, but it contributed greatly, I think, to the hysteria, because it became this almost political sideshow.
One thing that, sorry, we're jumping around a lot. I do want to get back to your photos, but one thing that I wanted to ask you about is, there was a symbiotic relationship between the media and NGOs when we're out in the field in crisis situations. How did this particular situation play out? I mean, the journalists needed you, but you didn't want them there because they were going to get in the way of your work. So how do you manage an emergency like this, where you need the journalists, you need
Sure.
the media, you want to make sure the coverage is responsible, at the same time you don't want them in your ETUs. So
Yeah, and that's the distinction. It's not it's not that we didn't want them there.
Right.
Far from it. We
But
or that we didn't specifically want, or don't specifically want media per se inside ETUs. We don't. It's any non-essential personnel.
Yeah, ETU is an Ebola treatment unit.
Ebola treatment unit. Nobody other than the essential medical staff can go in there, and that's purely for infection control reasons, purely for medical reasons, and to mitigate risk against unnecessary infections. In this instance, we certainly wanted and continue to want to facilitate media access, and we do to the degree that we can, and that's everything from up until physically into the high-risk areas in our facilities, to tagging along with outreach teams that are going out into outlying communities and doing public health awareness campaigns, to facilitating interviews with patients when and where possible. Literally over a barrier, over a fence or something. But it certainly requires a good amount of management and triage, and because at the early in the outbreak, when there was a real media crush, this is why we have communications officers on the ground, and to facilitate the media access and be kind of buffers between media and the medical teams. But it's something that we're used to. I mean, and we call them kind of CNN crises. When an earthquake hits Haiti, when there's a tsunami, when there's a conflict area to which there's relatively good media access. And we're there. We do have part of MSF's mandate really is to speak out, is to bear witness and speak out. So part of that, by definition, has to involve collaborating with media, and I think we have a rich history of, in the main, very positive collaborations. I think Getty can attest to that. John certainly, and his colleagues, and Todd as well.
I can vouch for MSF and Shirley.
And we can vouch
Yeah.
for media. I mean, there is that symbiotic relationship, and where we can arrange access. We certainly strive to. It's not always possible. We often get the request, especially from freelancers, who are on limited budgets, if they can embed with us. And sometimes that's possible, but to be honest, it's something that I and my colleagues will often discourage, and for a number of reasons. That if a journalist is going to embed with MSF, it means they're under MSF security rules. So especially in a conflict area. It means that if the team has to be in the compound by 6 p.m. on a curfew, so does the journalist, if we've assumed security responsibility for that person. So if at 6:04 there's shooting down the road, that you can't go and cover it. So there can be real restrictions with being overly dependent on MSF. But you know, with the Ebola crisis, I'd say this is the most exposed I think we've ever been. I mean, we've had tremendous media exposure, and so I think that speaks to the degree to which we've facilitated access. And you know, in this crisis, we've had to really court media. I mean, we've had very specific concerns. We were calling this an unprecedented outbreak from the get-go. That was disputed by the WHO and amongst others, and then they eventually came to agree. So we were really screaming. We've been screaming at the rafters and demanding a robust international response because, as the main treatment provider in the 3 affected countries, we can't handle the load, and so we've needed the media, very much so, to help amplify our messaging. And I would say in this crisis, the media have by and large been really important allies.
I should mention, I worked in the MSF ETU quite a bit, not in the high-risk areas, but you can see this picture right here. This is at their center, and that's a high-risk area. You can take a picture from outside in. You don't necessarily have to be right next to people.
Now, and this photo, as you probably know, has been at the heart of some ethical controversy the last few weeks. Other agencies, it's a Getty image. It's available on the Getty database. It's available for licensing. That is at an MSF facility, so that is an MSF worker with an MSF patient. Other aid groups have obtained that image for their own fundraising campaigns for Ebola, and it's something that we weren't too crazy about, and have received some apologies. But it does. I mean, it's one interesting aspect of the ethical, aspects of this, right? The ethical dimension of this is that, for Getty, that's something that's totally out of your control, obviously.
For sure.
Yeah, but of course, the image is captioned, but yet two other aid groups used it knowing that it's not their patient.
Right. Well, in this particular frame, we talked about permission for children. You can't see her, but behind the MSF worker is the mother walking behind, and I was able to speak with her as they went into this tent, and she said it was fine. Sometimes you photograph first, and then you have to ask later. That's just otherwise you don't get pictures. But I did find out that this child survived, as did his mother, her mother, excuse me.
Now, you shot the back of the child here. Well, that's what it looks like from here, right?
That's
and
right.
And then the other child who was naked on the bucket was from the back. Was that done deliberately, or that's just where you were standing?
I think in both cases for those pictures, it happened to be where I was standing. The other child I did photograph with his face on a number of occasions, but I was talking with his guardian. It was not his mother; it was his aunt. His mother had died a week before, and so I was talking with her quite a bit. And in fact, that whole family, the child on the bucket saw the surviving members of that family, and 3 out of the 6 children died. Surviving members all arrived to MSF, and I happened to be there at MSF when they arrived that day. So I actually have photographs of them being dropped off at the facility and then going inside. It's a lot of half of them lived. That's the thing about Ebola. I did a portrait series as well. I don't have those pictures here to show you, but on survivors. Because although there may be a 60-70% mortality rate, that means that 30% survive, and that's a lot of people. And when the survivors came out, in fact, I photographed them at MSF, a group who came out. Some of them wanted pictures, others didn't. And I photographed them. They were very happy coming out. They had just survived Ebola, imagine. But then when I went and photographed another group who came back for a meeting of Ebola survivors to talk about stigma, that group that came back wasn't so happy because they'd gone home, and they had a different perspective from when they left. One woman who I photographed, who had been a midwife and probably contracted Ebola delivering a baby. She said, my neighbors won't let me draw water from the community well. And that's, if we have issues with stigma here in the U.S., boy, do they have it over there. And it's an awareness campaign that has to continue, not just in defeating the disease, but in educating people about, there's no one safer than an Ebola survivor.
Right.
They're never going to have Ebola again. They're not going to give it to you, although it does exist in semen for several months, right? But generally speaking, they're not going to give it to you, and they're never going to get it and give it to you. And so that's the cruel irony for people who've gone through this terrible experience, is that they have to convince people that they're okay.
We've actually hired, some of the patients who have survived in our facilities have ended up to becoming MSF staff because they can work inside a treatment wards without PPE. So it provides actual human interaction with the patients, which makes it's a massive difference, because otherwise their only interaction is with people who are completely covered and concealed, who are caring for them, and it's actually it's a very nice kind of side story, and it's one that we've tried to communicate on as well, and it's actually gratifying to see. We've gotten a few media requests about, do you have any survivors who we can profile or who might be working for you, and so it's nice to see that interest. That media interest in that kind of cohort of patients.
Well, that's one thing we were talking about before, Todd, and I was wondering if you can quickly address it. And yes, we will take questions from the audience, but first we have to say our bit. But we were talking earlier about the need to have positive stories, and if you could address that, your love at the time of Ebola.
Sure.
Because it's soul-destroying work to do crisis reporting, don't you agree? And I think it is good to have positive stories, not to be a Pollyanna about it, but it's very, very important.
The survivor story is
Resiliency.
perfect. People actually, it doesn't kill everybody, and
Yeah.
there are survivors. And so I wrote this story, and I took a little grief for the headline, Love in the Time of Ebola.
I love that.
I liked it, yeah. But it was a story that, about a young woman from Baltimore, who was coming back to Sierra Leone, where her boyfriend was. She was out of country in the U.S. when the outbreak worsened. She lived in Sierra Leone for like a year. She was on one of these NGO or Harvard projects, some study project. And she didn't have to come back, and she came back only because her boyfriend was there. And they were committed to staying in Sierra Leone and making a life there and contributing and helping out. And of course, her family thought she was nuts, and how dare you go back? This is not safe. And her friends thought she was nuts. And so it was a way to sort of show a small humanity that that was going on there. I mean, there was also lots of positive stories there as well. And that was one thing we did struggle with, was how to not just make it into a doom and gloom story, because there are positive aspects of what's going on there.
That's a great way to avoid a classic, obvious trap in reporting on, humanitarian crisis, especially in Africa. I mean, the tradition of reporting from Africa, especially when you're showing, dozens of pictures of, at a distance, poor, children dying in their own body fluids, evokes, decades of tradition of portraying Africa in a particular way.
Yeah, the tropes. And
even though this emergency is very much an emergency, it's still worth kind of being cognizant of that, I was looking at a website today that's a popular news website for doctors, and the story was called Out of Africa, which already is, wonderful. And the graphic was the outline of the entire continent of Africa with that familiar, like, squiggly virus over the whole of Africa. Right. And it's just a wonderful, kind of subtle reminder of the tradition that lots of our development reporting has fallen into, that's worth just being cognizant of.
We're unfortunately running out of time, and I know people do want to ask questions. So I was wondering if maybe everybody in the panel can sum up any points that they feel weren't made before, and anything forward looking as well as to what we've learned from this coverage and where we're going with it in terms of how the story has evolved, where it might be going, and any other points you might want to make that we haven't covered.
Yeah,
Sorry
just
to put you on the spot. Do you want to start on that side?
I was quickly. I think because reporters are going to continue going, and it's kind of funny right now we're in a lull, I think, of interest of Ebola, right? It rises and falls, and just before we started, I saw that Emory has a suspect case, right? Mass General or whatever, Massachusetts Boston Hospital, they turned out not to have Ebola, but now there's something in Emory. So again, that could suddenly spike up. But I think the challenge for people covering it in Africa, right, is finding angles and ways to tell the story that are fresh. It's purely from like an inside baseball sort of perspective, like if, as a reporter going back or photographer going back, I mean, that's an iconic image right there. I mean, that's, incredible image. And you can't do that again, right? And you need something fresh. And so the challenge is to keep the story interesting enough so that people will continue paying attention to it.
How do you do that?
It's interesting. We face a similar dilemma because
Right.
we also struggled at times to come up with a new angle, or just try to maintain the attention. We communicated yesterday about the where things stand with the international response now about 3 months in, and it's uneven, and it's not all the needs are not being addressed, and it's been very, very slow, rather ill adapted, and there's been some receptivity to that, but it's similarly it's for us we face a not dissimilar challenge in keeping this on the media radar, but again, I would just return to what I mentioned before specifically about the coverage here. If there's a possible case now at Emory, this is when you have a spike in news about Ebola. It's Ebola's back in America, and it's at the expense of, again, focusing on it, or putting the focus where it absolutely needs to be, and I wish I had a magic formula to get around that, to shift that focus. I don't know what it is, but I think if there can be some reflection, and I think it would be great to have a panelist of journalists who covered this domestically, to really reflect on the kind of the pros and the cons of the coverage, because I do wonder about the how what kind of a service was actually provided, if the public was really served by their media. I think that's an important discussion to have.
Same deal, I think. And just to reiterate what those guys said, we're at the crisis fatigue point, right? This is the zone of the acute phase being over, and the images continue, and we're at the crisis fatigue point where it's either I just can't take this anymore, or there's a new angle, or something else happens, and this is the time to try to figure out root causes. And I would love to see. There have been some great stories on root causes, but it's that time a little bit. We didn't talk much about the media that all the NGOs are putting out, but over the last few years, the volume and quality and depth of media that are being produced by organizations, not just like MSF, but by IRC and IMC, it's worth paying a lot of attention to that stuff too.
Well, I think there's still plenty of stories to be told there. The press, it doesn't seem that way from the U.S. angle, I suspect, because we've had so much coverage, a lot of it in the U.S. For these very few cases that existed here. But actually, on the ground in Liberia and I think Sierra Leone and Guinea as well, considering the massive interest in this story, and public attention. There were actually very few people on the ground, considering the size of the story and the sustained size of the story for weeks and weeks. There were far fewer journalists there than you normally see on a big story. And why was that the case? I'm sure it had to do with fear, not just of journalists who would normally go into conflict zones, who would normally go into battle zones, and risk all sorts of physical disasters, but also editors. I think a lot of editors for news organizations. I believe Reuters never even sent one international photographer over, and that's an organization that aggressively covers the news, and so it just basically freaked out a lot of people in the business. And so there weren't that many people on the ground. I think there's a ton of stories that have not been done, and there's a million ways to tell the story, and hopefully it'll be a happy story. It'll be kids going back to school. It'll be a legislature, however functional that is in Liberia, or functional as it is here in the U.S., going back into session. It'll be hopefully a country starting to get back on its feet, and I think there's lots of stories to be told.
Questions? Hi, Margot.
I just have a quick question concerning government officials there on the ground, such as in Guinea, the government of Alpha Condé, tried to hide some information about Ebola and what's going on in the country, and I wanted to know, in terms of an organization such as Frontières or newspapers such as the Washington Post, how you get information from them and how they collaborate with you guys on the ground in the field.
In any country in which MSF is working, there's an MOU, there's a memorandum of understanding. We're there under the with the authorization of a host government. And certainly, I mean, if you read Adam Nossiter's piece in the Times yesterday, which was really almost a TikTok of the evolution of Condé's how he dealt with and is now dealing with the outbreak. It talked a lot about his interactions with our head of mission in the country, et cetera. So there is that level of discourse. That's atypical, I would say, in this particular crisis. We're certainly interacting at the level of ministers of health, if not presidents. And that it is at that level of interaction, but that's quite exceptional. I mean, these are overwhelmed governments, and MSF, has you referenced being in then Zaire during the outbreak. I guess it was the Kikwit outbreak, and MSF was there and the main treatment provider. So we have some experience with Ebola and other hemorrhagic fevers. So we bring a level of expertise that these health ministries simply don't have. So this is there is an exceptional level of interaction. And we do tend to tell it like it is as an organization. Sometimes that's perceived as brash, if not arrogant, and we'll accept that. And I think Adam's piece yesterday, captured some of that spirit. The discourse with the president was very direct. And that was, I think, reflected in some of the quotes in the piece. In a crisis like this, one needs to be, while diplomatic, it needs to be very blunt. And there was concern, and I think it prompted our exceptional call in late March. When we called the outbreak in Guinea, it hadn't yet spread to the other countries, but it had spread to Conakry to become urban. And we called this an unprecedented outbreak of Ebola. And it was precisely because of its geographic breadth within Guinea at the time. And we were, I think, motivated to issue that call precisely because of some of the resistance, some of the political resistance that the teams were facing on the ground. almost a kind of head in the sand type approach. But credit where it's due. You know, the government is gains were made, and they accepted the gravity of the situation and speak openly about it now. So, you know, it's I'd say it was a positive discourse.
Sierra Leone made things very difficult. Not because they were bad people, but they just really wanted control over the message, and they were very worried about that. Understandably, I guess, you don't want to panic people. I'm not sure what they imagined, actually. And so they tightly controlled the local press, who I had a lot of interaction with, because, like I said, there weren't many international reporters there. And from my understanding is that Liberia was a little bit easier to work in, but has since clamped down as well. But like, you know, they set up these quarantines, you know, essentially to keep people from, well, they also use those quarantines to keep media out, right? And I remember in Sierra Leone, you had to get the special pass to get through the quarantine that you could only get from the EOC, the Emergency Operations Center, and you had to go through like 6 different hoops. I remember I tried to meet a government minister who I'd worked with in the embassy here in D.C., and I thought I had everything laid out, and when I got there, and the guy just pretended like he didn't know who I was, and it was just jumping through different hoops. And so the way around that was just to not ask permission, and if you were able to hitch a ride with the Red Cross or some other group that was allowed through, that was the way you could get around that. But, you know, they really wanted more control. I feel that they felt like there wasn't control, and they wanted more control.
Well, in Liberia, it was easier to work early on, and they did clamp down. And part of that had to do, frankly, with there was one photojournalist who was told that they could not go into a certain Ebola treatment center, and then found a way to get in. And it absolutely infuriated the woman who ran the hospital, and she was powerful, and the government came down with a new rule that made it a crime for us to go inside any of these places. And so I suspected that would happen. But between my first and second trip, you know, at some point, someone's going to behave badly and make it hard for all of us to work, and that was the case. And so yes, it's become more difficult in Liberia as well. But fortunately, it looks like things are getting better there, and hope that continues.
Where do you draw that line between behaving badly and not asking permission? Because there are certain circumstances when, as a journalist, you kind of just need to push through a door that may not necessarily open for you. And where, you know, how do you make that decision where maybe I shouldn't go in here because it will complicate the situation for my colleagues?
Well, in that particular case, she had approached the director of the hospital the day before and said, "You can't come in," and so that was pretty clear. But yes, of course, we push the boundaries as much as we can. Otherwise, you simply don't cover an event. You can't cover it, and you try to do it responsibly. So it's of course that line is. It's different in every situation, but as long as you try to treat people with respect and bend the rules as far as you can safely, without breaking them specifically when you've been told not to do something, then that's kind of where we go. It's a dangerous environment and hard to work, and you had to do what you could within reason.
I think that might be complicated sometimes, too, in this type of situation by that symbiotic relationship between NGOs. I think lots of journalists working in settings like this one are dependent on NGOs or other aid organizations, not just for stories and sources and fixers, but for oftentimes security and shelter. And that relationship complicates that question, I think, a little bit, because you certainly don't want to lose that part of it, that symbiosis, and become a parasite.
Michael, I wanted to ask you a question a little bit. Catherine Maloney.
Of course, yes.
My background is in medicine as well. What's interesting to me, one of the scariest parts of this whole reporting to me, when I saw a headline that said should we, thank you. You asked how should we start to rethink about this or reframe this. And one idea is to really take this back to a global health perspective, which is this is about Ebola, the virus, but this is about two separate diseases on both sides of the water. So one is really an international security issue besides the infection. On the US side, on both sides, this is about healthcare systems. We have an incredible healthcare system in the United States. I am not at all afraid of going onto the New York subway and getting Ebola. In West Africa, the story really is about healthcare systems. And I think that there are unintended consequences that we need to sort of start raising that may help us reclaim some of that land. So for example, bring it back to a discussion of vertical healthcare systems and horizontal healthcare systems. We see these images and they're so important, but I'm very concerned about maternal morbidity mortality, neonatal morbidity mortality. Where are those stories? We're seeing this from a donor perspective as opposed to necessarily a recipient's perspective. I think that's a critical storyline to pursue. I think the other unintended consequence is a political one. And when you have politicians who are dictating our quarantine measures or going over and above the CDC, then to me that means that the medical community has failed. We have failed to claim that area of expertise. And in doing so, perhaps we've actually compromised national security even more. So say, for example, I'm sure your recruitment campaign to get physicians to go to West Africa is now very, very difficult because whoever goes has to sort of potentially go through quarantine on coming back. And that will have an unintended consequence of actually making diagnosis treatment in West Africa, getting a hold of the epidemic even worse. So the question is, given where we are, how do we reclaim some of that space? Because we know this is going to go on for months to come. And I think it's important, particularly in the United States, to reclaim the expertise of this disease. And it isn't just about Ebola, it's about healthcare systems. And maybe start changing the language so that the New York Times, it isn't about Ebola on the front page, but it's healthcare systems, healthcare systems.
Yeah, one of the aspects and we could probably be speaking about this more, MSF, is the effect of the effective collapse of the healthcare systems in these countries because of the Ebola crisis. We certainly spoke about it earlier on and have communicated about some of the activities that we've done to try to fill that breach, and it's a significant breach. We're doing we've scaled up our malaria work, not just significantly, but in innovative ways as well. But certainly, these were fragile health systems in these countries to begin with, and the knock-on effect of this crisis on public health in these countries is not insignificant, and will arguably have a longer-term implications than the hopefully relatively shorter-term implications that Ebola presents. So, could we be communicating a bit more about that? Yeah, we probably could. But it's all part of also trying to communicate about the relatively slow international response, and the ill-adapted international response, amongst innumerable other priorities. In this country, I can only speak for MSF, and there's less for us to communicate on in terms of the domestic, other than what I'm sharing with you, which is in part in a personal capacity. But we're not a healthcare provider in this country, and had no involvement with the thankfully few cases of Ebola that have arisen. But I don't know if that quite answers the question. But
MSF is in a very unenviable position given the sentinel failures in the international disaster response system from the WHO.
Yeah.
I love your
And
comment that screaming to the rafters. MSF
Yeah, and And we have from the beginning, and about your point about recruitment, I mean, we, as soon as the quarantine measures were announced, New York State and New Jersey, one of the first things we said, and quite loudly, was, there's the potential for a chilling effect here, which will actually undermine exactly what you're trying to protect, that will go against public health. And we weren't the only ones saying this. I mean, Tony Fauci was very vocal about this, the head of the NIH, and Tom Frieden at the CDC as well. I mean, they were really in lockstep. And yet, and they were very, very clear, on everything from travel bans are counterproductive. Sealing off these countries will actually further, there's a potential for greater harm. And reminding about how Ebola is, and more importantly, is not transmitted. And yet, the fear was there. And it's an incredibly difficult thing to penetrate. And, I mean, our colleague Casey Hickox really said it best in an interview on the air, after Dr. Christie said on the record, well, she's sick, and so she's exactly where she needs to be. And then she was interviewed and said, I didn't realize that Governor Christie was a doctor. Or as far as I understand, he's not a doctor. He hasn't seen me, and I have no symptoms. I'm not sick. So, the facts almost didn't matter. And so, and the facts surrounding this virus almost didn't matter.
Do you have anything to add?
Yeah, I mean, absolutely, those systems issues are probably the most important thing we're talking about. In a sense, they're one of the hardest things to tell a relatable story about at the same time.
Yeah.
And some of those issues, regarding systems development often generate a lot of controversy even within the global health community. And so from a reporter's point of view, I think it's probably hard to get a hold of some of those issues or get a good grasp on some of them, some of those stories sometimes. But, this is a systems issue domestically for sure as well. We have spent, I don't know how, I can tell you, yesterday we announced, or the White House announced yesterday, that the existence of 35 treatment centers throughout the U.S. at the cost. So that means throughout the country today, there are 35 Ebola treatment units that are technically up and running, which means we have the capacity to treat 35 patients.
Right.
At the cost of millions and millions. My hospital has spent millions of dollars in the last month enabling us to take care of one patient.
They're all one patient each?
For the most part. We can handle one.
So it's like,
Bellevue can handle two, but has made it pretty clear that they're not interested in two. So, plus or minus, it's pretty.
That's really interesting. Yeah.
We converted in the last 3 weeks a 12-bed intensive care unit into a 1-bed biocontainment unit.
Oh, wow.
And that's been repeated over. So this is a systems issue when you think about the possibility of something like pandemic flu.
yeah. Has everyone gotten their flu shot?
Get your flu shot.
Unfortunately, we don't have the room much longer. I can take one more question from somebody who
Okay.
hasn't spoken, and then afterwards, if you want to ask people questions privately.
Okay. So I have just a two-part question, part of which was raised by the discussion here. Pretty early in, I think, Ebola being in the United States, I remember I was looking at some of the coverage about how it's passed on. And most coverage referred to a statement that was pretty much also in, I think, CDC publications that said something like direct contact with bodily fluids, e.g. blood, and I think it mentioned one more, maybe urine, maybe semen. And all of the coverage repeated those lines, which made it sound very much like HIV infection, which is not done through casual contact. It has to be direct contact to blood and other fluids like that. But at the time, I was wondering, some of the description of what was happening in West Africa, for example, the precautions that people were taking, made it seem a lot more like the way you could catch a cold through, someone releasing droplets in their, when they cough or sneeze or something like that. That was not anywhere in the coverage. So where I did see that was this is pretty early on I'm talking about, where I did see it was in discussions on web pages of news stories where thousands of people were saying, but what about this, but what about droplets? And at the same time, I saw it's not really a media outlet, it was more like a blog or something, and as I looked at the rest of it, it was sort of a very right-wing kind of place, discussing how the government isn't telling you that it can be airborne, and they'd have a link. And I think a lot of people wouldn't bother to click on the link, but it was talking about the possibility of the virus mutating to become airborne. And then in addition, they'd say they've also proven that it can be communicated through air. And when you click on that link, it's studies showing that when they actually inject air into the nose of willing, I don't know where they found these willing subjects, but willing test subjects, they did indeed catch Ebola. So that's very extreme. But at the other hand, what I was seeing, and I was looking at most of the major print outlets online, referring just to direct contact with bodily fluids and only listing things like blood, leaves out saliva, leaves out, moistures. So things like what you mentioned earlier, aerosolized droplets, only came into the coverage, to my knowledge, much later on. So the public is looking at the contradiction between this description of something that sounds like it's not easily transmitted like HIV, but on the other hand, people are taking tremendous precautions wearing this protective covering. Something doesn't add up. So I personally thought at that point, if I were to cover the story, I would want to get somebody who was an expert on the subject, not just your random doctor, and say, how well do you know this? Tell me, list for me every single bodily fluid it can be communicated by. How about droplets of moisture in the air? And then I would also want to ask, look, this is a new disease. It's been around a few decades. It's happened mostly small outbreaks in faraway places, very far from where major research is done. So I don't know how accurate the research on how it's communicated really is. So I would want to know, how sure are you about this? And I thought to myself, if I were to write that, what would be my responsibility about, I don't want to lie to anybody who's reading my article, but at the other hand, I don't want to raise panic either. I tend to think that the media's responsibility is more to put the facts out, not to manage how people use it. That was my first question. I came into this.
What's the question?
It's a statement.
No, generally, like, how do you think the media should handle asking these kinds of detailed questions and putting the information out there? So that's the first part of it. But having
Okay, I think
listened
we
to
all
the
agree we should be doing that.
having listened to this discussion here, though, I want to say, and I don't mean to put you on the spot, but there's a contradiction right here in how you're discussing this. On the one hand, two of you who've covered this have spoken about you were concerned about the health of people around you in West Africa. And therefore, you wanted to keep a certain distance away. Your fixer was telling you you're getting too close. You were worried about your fixer and what if he got sick. And when you said that, many people here, myself included, nodded with understanding. We would feel the same way if we were in your position. At the same time, you've also said that the Washington Post did not want you back in the office for 21 days. Mm-hmm. And the same thing with Craig Spence was not wanted back at Columbia, which understandably has a very vulnerable population of patients.
Columbia is not said that they don't want Dr. Spencer back. He will return to work.
Initially.
Columbia has not at any point said that they did not want him.
Okay, but he didn't go into work. Was that his own choice not to go into work?
That was his choice.
Okay, fine. But in any event, I would understand it with Columbia because you do have patients there. But the Washington Post did not want you back initially for 21 days. So there's a bit of a contradiction to me to take those precautions, but at the same time to be saying that the public was wrong to think that Craig Spence was out and about and right up until he had a high fever, because the risks that you were willing to take as doctors are rather like a firefighter who knows he may die of smoke inhalation or fire.
I think you're
Right,
conflating some issues, though,
yeah.
because I agree with you that there's a disagreement about the bodily fluids thing, but I think everyone, and somebody here's a doctor, so blood, urine, saliva is the big missing one right off that list. And then the one that I think is contentious is actually sweat. I mean, we actually had a fight about this in the newsroom, and I think there's like one study, or maybe it's inadequately studied, about whether it's actually found in sweat, right?
Well, I think that there's no, this is really confusing, right? This is really hard to communicate.
Yeah.
And it certainly, we know it certainly has to do with viral burden as well, and infective burden. So the key point, and what you're mentioning also is the other thing that you've heard over and over, which is that we don't feel that before someone becomes symptomatic, they're able to be contagious with this condition. Now, whether or not your driver is symptomatic in the morning, to me, seems like a much harder question to answer than the question of whether or not someone is symptomatic who has been specifically instructed to fill out a checklist every day that says, are you nauseous, are you vomiting, do you have diarrhea, do you have fever, and whatever else. is on that checklist.
And I think the other important thing to remember is that in the case of Dr. Spencer or anyone who ultimately develops symptoms symptoms of Ebola, is that prior to him becoming febrile, prior to him developing the fever, he was in no way contagious. He was not symptomatic. And partly what's lost in the discussion is at what point someone becomes contagious. They have to be highly symptomatic. And my understanding, and I'm certainly not a medical person, but I do work for a medical organization. And my understanding is that he arguably was not even symptomatic when he reported the fever. That the viral load was still at a level that he would not have presented an infectious threat. So the suggestions that were out there that he was, recklessly going around the city and then he dared to go bowling and posed some kind of public health threat is simply not based on sound, accepted medical science.
Okay, but
If he was symptomatic. If he had been symptomatic.
okay.
If they had been symptomatic.
Unfortunately, we do not have this room anymore. But I think it's a good note to end on, which is that it's really, really important to get the media and medical people together in forums like this and others. And I think this is really, hopefully at Columbia, well, we've already had one at the medical school, but I think the answer to both of your questions or statements are that we need to have closer communication between these two communities. And that will help serve both in terms of getting out reliable information to the public. Anyway, thank you, everybody, for coming.
Thank you.